Today, we are reviewing a clinical trial abstract detailing the phase 3 results of perioperative Enfortumab Vedotin and Pembrolizumab versus surgery alone for muscle-invasive bladder cancer. The presentation of the hazard ratios and survival percentages lacks a comparative contextual anchor that fully illuminates the clinical magnitude of these findings.
Yeah, the fundamental weakness we're looking at here is a classic case of the data just being so good that the author basically assumed it didn't need an introduction.
Right.
Because we are looking at, a hazard ratio of 0.4040 for event-free survival.
Which is huge.
Exactly, it's massive, and a 48.3 percentage point jump in pathological complete response, but the text just drops these practice-changing numbers with the exact same flat, academic cadence that they use to describe the basic statistical methodology.
Yeah, it's very dry.
Very dry. And by assuming the raw statistics speak entirely for themselves, the text completely misses the opportunity to establish just how disruptive this intervention is for a cisplatin-ineligible population.
Right. As I understand it from the notes, the argument here is that this specific regimen is highly effective, but that effectiveness is kind of buried under this massive assumption of prior knowledge.
Exactly.
We're looking at a leap in event-free survival from 39.4% in the control group to a staggering 74.7% in the treatment group.
Yeah, it's a completely different world for those patients.
It really is. But wait, let me play devil's advocate for just a second here.
Sure.
Because this is a scientific abstract, right? It's likely bound for a major oncology conference or, a high-tier journal. Isn't the entire point of an abstract to strip away the narrative and just deliver the raw objective data?
Well,
Like, the readers are oncologists. They know what a 0.40 hazard ratio means. Why do we need to contextualize it for them?
Yeah, so that's a really common assumption, and it's honestly exactly why so many abstracts fail to make a real impact.
Oh, really?
Yeah. Yes, the reader is likely an oncologist, but we have to consider the cognitive load of how these professionals actually consume literature in the real world.
Okay, fair point.
A fast-scanning clinical reviewer or, a physician reading through 50 of these abstracts over their morning coffee?
Right, they're skimming.
Exactly, they're skimming. They don't have the mental bandwidth to stop, pull up the historical baselines for cisplatin-ineligible patients from memory, and run a comparative analysis on the spot.
Yeah, I see what you mean.
If the text doesn't explicitly frame that leap, those numbers just blend into the endless sea of trial data. You have to guide the reader's perception.
Okay, I see the distinction. It's the difference between supplying data and supplying insight.
Precisely.
Presenting these numbers without historical context is it's like announcing a revolutionary new engine design by just listing its torque specs without mentioning that it actually doubles the speed of the previous standard.
That's a great analogy.
It forces the reader to basically supply their own astonishment.
Right, which you don't want to rely on.
So if we want to fix this without violating the strict word count constraints of a medical abstract, because those are always tight, how do we actually do it?
Well, we need to introduce a brief qualitative framing device right at the outset. Just a baseline expectation.
Okay, where would you put that?
I would suggest looking at the background section first. Instead of just stating the disease state and the drugs being used, we could drop a single sentence in there that establishes the historical reality.
What would that sound like?
Something like, historically, outcomes for cisplatin-ineligible patients relying solely on surgery have remained poor, with a critical need for viable systemic options.
Okay, so what I really like about that part is that it doesn't inflate the data.
No, not at all.
And it doesn't use hyperbolic language either. It simply calibrates the reader's expectations. You're setting the floor incredibly low so that when that 74.7% survival data finally hits in the results section,
The ceiling feels infinitely higher.
exactly.
Yeah, it creates a narrative arc using purely clinical terminology.
That's clearly laid out. I wonder, though, if we've considered what happens if they just literally don't have the characters for that in the background.
Yeah, character limits are brutal. If they don't have the space there, they could achieve a very similar effect in the conclusions section.
Okay, how so?
Instead of just summarizing the data as significantly better, which, let's be honest, is a bit of a throwaway phrase.
Yeah, everybody says that.
Right. They could frame it to reflect the clinical reality. The conclusion could state that this regimen represents a fundamental shift in the anticipated baseline outcomes for a historically difficult-to-treat population.
Oh, that's good. That's a much stronger anchor.
It really grounds it.
But setting up that massive clinical benefit inevitably brings up the other side of the clinical coin.
The toxicity.
Exactly. Okay, so we fixed the shock value of the survival data. But massive benefits in oncology usually mean massive toxicity, which brings us to the second major issue in this abstract.
Right.
The compartmentalized handling of the adverse event data misses a critical opportunity to proactively address the inevitable clinical apprehensions regarding the treatment's high toxicity burden.
I'd argue this is probably the most glaring structural misstep in the entire abstract.
Oh, absolutely.
The text bluntly states that grade 3 or higher adverse events occurred in 71.3% of the treatment group versus just 45.9% in the control.
Wow.
And then it just stops.
It just leaves it there.
It leaves this alarming statistic hanging in absolute isolation at the very end of the results section. It completely fails to correlate this severe toxicity with the survival benefit or even to discuss tolerability.
Yeah, let's look closely at the section discussing these safety endpoints, because reading it as an objective outsider, I found the sequence incredibly jarring.
It really is.
We read about the incredible survival benefit, and then suddenly, bam, we hit a 71.3% severe toxicity rate.
Right.
And grade 3 adverse events, they're not minor.
No, they are medically significant.
Yeah, my immediate thought was, wait, will these patients even tolerate this aggressive regimen well enough to actually make it to the operating table?
And that's exactly what every clinician reading it is going to think.
Right. In a clinical trial abstract, suspense is the enemy of clarity, and leaving that question unanswered right next to the safety data creates massive suspense.
That is the exact cognitive gap we need to close. When you silo the safety data away from the efficacy data, you force the reader into a state of clinical apprehension.
Yeah.
A surgeon reading this is going to immediately worry about perioperative dropout. So the suggestion here is to synthesize the safety and efficacy data rather than isolating them.
Synthesize them how?
The text needs to proactively provide a risk-benefit framing right there in the narrative.
I have to push back here, though.
Okay, go for it.
If we start massaging the toxicity data with phrases about risk-benefit synthesis, don't we cross the line from objective data reporting into subjective marketing?
That's a fair point.
Like, if a drug has a 71% severe toxicity rate, doesn't the author have an ethical and scientific obligation to just state that number bluntly and let the chips fall where they may? If we try to, frame it, aren't we spinning the data?
That's a very fair concern, and maintaining objectivity is paramount in these abstracts. But synthesis is not spin, it's context.
Okay.
Is there a risk that focusing solely on the raw toxicity numbers might overlook the actual clinical manageability of the regimen?
I mean, I suppose so.
Yes, absolutely. Because think about it. A 71% toxicity rate that results in total patient dropout is a failed drug.
Right.
But a 71% toxicity rate where the side effects are completely managed and the patients still get their curative surgery, that's a medical breakthrough.
Oh, I see.
By separating the toxicity from the surgical outcomes, the author is actually presenting an incomplete picture of the drug's safety profile.
Ah, okay. That makes sense. The manageability of the toxicity is a data point in itself.
Exactly.
So how do we weave that into the text organically without adding too much fluff?
We take a data point that already exists elsewhere in the abstract, and we just move it.
Which one?
Somewhere in the secondary endpoints, the author notes that 87.6% of the patients successfully underwent surgery.
Okay, yeah.
We need to physically append that fact to the adverse event data, so we could revise that section to read, while grade 3 or higher adverse events were notably higher in the combination group at 71.3% versus 45.9%, these were managed within the protocol, allowing 87.6% of participants to successfully proceed to surgery.
Oh, wow. I can see what you're going for here. Let's see how we can strengthen this even further. By putting the 87% surgical completion rate in the exact same sentence as the 71% toxicity rate, you create an immediate counterweight.
Right.
It answers the reader's apprehension the exact second it arises.
It neutralizes the alarm.
It really does.
And we can apply this exact same philosophy to the conclusion, too. The revision could explicitly weigh the two factors, stating something like, Despite a higher incidence of severe adverse events, the perioperative combination demonstrated a manageable safety profile, leading to significantly better survival.
That's great. You aren't hiding the toxicity. You are accurately describing how it functions in the real world.
Exactly.
That makes perfect sense. So we've contextualized the survival data so they understand the benefit, and we've synthesized the toxicity data so they understand the risk.
Right.
But none of that matters if the reader actually wants to prescribe this regimen and can't figure out the dosing schedule.
Oh, the dosing schedule.
Yeah, which brings us to the third critique. The strictly parenthetical structure used to describe the complex dosing schedule obscures the actual sequence of the patient journey, making the real-world application of the trial unnecessarily difficult to visualize.
This is heavily rooted in syntax and, honestly, the misuse of punctuation.
Yeah, it's a bit of a mess.
If we look at the methods section, it attempts to cram an incredibly chronological and complex protocol into this dense, heavily nested parenthetical block.
It's hard to read.
It is. We are talking about 9 total cycles of Enfortumab vedotin with specific day 1 and day 8 dosing, plus 17 cycles of Pembrolizumab every 3 weeks, and a surgical intervention strategically placed after 3 cycles.
Right.
All of this is shoved between a set of parentheses. It severely disrupts the natural flow of the text.
I mean, reading this methods section is like trying to bake a complex cake, where the crucial preparation steps like, the oven temperature and the baking times are hidden deep inside parentheses right in the middle of the ingredients list.
Exactly.
Rather than being laid out chronologically in the instructions, you're constantly jumping back and forth.
Yes, it's exhausting for the reader.
But again, let's look at why the author might have done this.
Journal guidelines.
Right. Character limits for these abstracts are brutal.
They are.
Authors use parentheses because it saves words. They're basically trying to turn a clinical timeline into a highly compressed mathematical equation just to save a few lines of text.
That is undeniably why they do it. The pressure to meet a 250-word or, 300-word limit is immense.
Yeah.
But sacrificing chronological flow for character count is a false economy.
How so?
Because clinical protocols are highly consequential sequences of events. When the syntax actively fights the chronology of the intervention, the reader's cognitive load spikes.
Right, they get lost.
They have to stop reading, pull out a mental calendar, and map out neoadjuvant versus adjuvant phases. The text needs to mirror the passage of time for the patient.
The material makes a strong case for the specific regimen, but the delivery of the timeline is a roadblock.
A massive roadblock.
A medical oncologist mapping out infusion chair time needs to visualize the workflow. So how do we unpack this parenthetical data and streamline the narrative without blowing up the word count?
Well, we break the mathematical equation back down into a linear progression.
Okay.
We basically walk the reader through the clinic doors alongside the patient. Instead of nesting the cycles, we could write it sequentially.
Give me an example.
Something like, participants received 3 neoadjuvant cycles of Enfortumab vedotin on days 1 and 8 and Pembrolizumab on day 1 every 3 weeks. Following radical cystectomy, participants completed the remaining cycles in the adjuvant setting for a total of 9 and 17 cycles respectively.
Oh, that's a massive improvement in readability.
Isn't it?
Yeah. You get the pre-surgery phase, the surgical event, and the post-surgery phase in the exact order they occur in reality. You don't have to pause and solve a puzzle.
Is the connection between the dosing cycles and the surgical timeline fully established in the material, or is that an area to potentially bolster?
Well, the way you just phrased it definitely bolsters it.
Right, and if word count truly is at an absolute premium, like they can't afford a single extra word, there's another option.
What's that?
If the author absolutely must keep it to a single, tight sentence, they can simply remove the parentheses entirely and just use commas to guide the timing.
How would that read?
It could read, the regimen consisted of initial neoadjuvant treatment, followed by surgery after the 3rd cycle, and concluded with adjuvant therapy to reach 9 total cycles of Enfortumab vedotin and 17 of Pembrolizumab.
Oh, I like that.
By writing it as a narrative sequence without brackets, that connection becomes undeniable.
And it flows so much better. It takes the same amount of space, but the saccadic eye movements required to read it are drastically reduced.
Yes, exactly.
You aren't bouncing into and out of brackets constantly.
Right.
You know, when we take a step back and look at the entirety of this critique, a very clear structural theme emerges.
Yeah? What's that?
every single issue we discussed today stems from treating an abstract purely as a data repository, rather than a narrative document.
That's a really great way to put it. The data is the foundation, obviously, but the structure determines if the reader actually comprehends the building.
Exactly.
We began by addressing the need to establish a contextual baseline for the massive survival data. If you don't tell the reader how poor the historical outcomes are for cisplatin-ineligible patients, a 0.40 hazard ratio just loses its impact.
Right. And from there, we move to the necessity of synthesizing the high toxicity rates with a risk-benefit framework.
Right.
We addressed how separating the 71.3% adverse event rate from the 87.6% surgical completion rate creates this unnecessary clinical apprehension. By physically linking those data points in the text, we proactively answer the reader's most pressing questions about tolerability and dropout rates.
And finally, we discussed linearizing the complex dosing methodology. By unpacking those dense parenthetical structures and aligning the text with the chronological reality of the patient journey, we vastly improve the real-world applicability of the trial design.
Yeah, it makes it so much more usable.
The overarching goal is just to focus on the holistic narrative flow.
Because the data shouldn't just state isolated facts. It must cohesively tell the clinical story.
Exactly.
From the initial lack of systemic options, through the rigorous but manageable treatment timeline, to the ultimate, highly successful outcomes.
Well said.
We highly encourage the listener to implement these structural and narrative changes to the manuscript. Once you've revised the abstract to reflect this deeper contextual and chronological flow, please submit your work back in for another critique.
We'd love to see it.
Because at the end of the day, when you have data with enough torque to double the speed of the current standard of care, you really don't want to hide the engine specs in the footnotes.